Hello students, welcome to the discussion of the MCQs in the subject Pediatrics for the Foreign Medical Graduate Examination. I am your Pediatrics faculty, Dr. Ashutosh Agarwal. Here I have tried to cover the most important topics for the FMGE exam. So first question we say is, a child is being evaluated for nutritional disorder. He is being considered to be a case of marasmus. Which of the following criteria is used to label the child? So you just here is asked for what is the criteria for the marasmus, and in this we remember the classification called as the Wellcome classification. Wellcome classification. Now the Wellcome classification is based on two things. One is the weight for age, and overall if somebody asks you which is the best indicator for malnutrition, it is weight for age, because weight for age is a marker of both acute and chronic malnutrition. And second particularly is edema. If the weight for age is 60 to 80% of expected and edema is absent, this is called as the undernourished child. This is called as the undernourished child. If the weight for age is 60 to 80% and edema is present, this child is called as the kwashiorkor child. If the weight for age is less than 60% of expected and edema is absent, you call this child as marasmus. And if it is less than 60% and edema is present, so if you see here, less than 60% you label as marasmus, edema is present, you say kwashiorkor. So if both the criteria is fulfilled, this is called as the marasmic kwashiorkor. This is called as the marasmic kwashiorkor. So this is particularly the Wellcome classification, right? So in this question, the criteria for marasmus has been asked, and if you go to the choices, the weight for age is less than 60% of expected and there is absence of edema. This is the criteria for the marasmus. This is the criteria for the marasmus. If you see the first criteria, this is undernourished. This is weight for age 60 to 80% edema. This is kwashiorkor. Less than 60% and presence of edema. This is marasmic kwashiorkor. Moving on to the next question. A child is born to a 34-year-old female and at birth is suspected to have Down syndrome. Which of the following features at birth is not consistent with the diagnosis of the Down syndrome? It's just they are asking here, what is the clinical features in the Down syndrome at birth? So at birth, if you see the child is flat from front, flat from behind. That is what you see is the midfacial hypoplasia. Midfacial hypoplasia with flat occiput. If you see above, there can be presence of the third fontanelle. There is presence of the third fontanelle which is present. If you look at the tone, there can be hypotonia, and way of framing the MCQ can be, due to hypotonia there is bilateral poor morose reflex. If you see the overall skull size, there is microcephaly which is present. If you see in the eyes, there is an upward slant, that is what we call as the upward slant of palpebral fissure, which is also called as the Mongolian slant. If you see in the hands, the point you can get is a single transverse palmar crease. And this single transverse palmar crease is also labeled as simian crease. Single transverse palmar crease is also labeled as the simian crease, right? And if you see the toe, there is a wide gap between the first and the second toe. That is what we call as the sandal gap. So there is particularly increased sandal gap. So if you see here, this B, C, D, all the things can be seen, but polydactyly usually is a feature of Patau syndrome. among the chromosomal disorders which are associated with the increased maternal age. You can simply remember P for Patau syndrome and P for polydactyly. That's the way of remembrance, and hand features are important to be remembered. In Down syndrome, single transverse palmar crease, simian crease. In the Patau syndrome, polydactyly. And in the Edwards syndrome, you get is the overlapping of digits. In particularly the Edwards syndrome, we get is the overlapping of digits. Overlapping of digits. Right? So this was the question on chromosomal disorder. Moving on to the next one. A 3-year-old child comes with bowing of legs since 3 months and is suspected to have vitamin D deficiency. All of the following can cause this except. Now particularly what you need to understand is vitamin D, right? This is something which is fat soluble. So in case of cystic fibrosis, there is fat malabsorption. So if there is fat malabsorption, there will be definitely vitamin D deficiency. This is true. Then is phenytoin therapy. Phenytoin is a hepatic enzyme inducer drug. This is basically a hepatic enzyme inducer drug, and it can convert calcidiol into inactive metabolite. Calcidiol is basically produced by the liver. So this can convert calcidiol into inactive metabolite. So if the calcidiol will be inactive, what will not be formed? Calcitriol will not be formed, and the vitamin D absorption will not take place, or calcium absorption will not take place, right? Vitamin D will not be formed. So this definitely can cause vitamin D deficiency. Renal tubular acidosis may be proximal, may be distal. If they are for long duration, both of them can cause release of calcium from the bones, which acts as buffer. Very long duration. So there can be what? Release of calcium from bones. Release of calcium from bones, which particularly acts as buffer. So this can definitely be seen here. So what is left now is the tropical sprue. Tropical sprue mainly affects the ileum, and if the ileum part is affected, this results in the vitamin B12 deficiency. So rest all are the causes of the vitamin D deficiency. Most common cause of congenital adrenal hyperplasia is 21-hydroxylase deficiency. Which of the following is true regarding this? So if I just discuss the condition CAH, congenital means since birth, hyperplasia means increase in the size of adrenal gland. So in this condition, there is increase in the size of adrenal gland since birth. And why it take place? There is decreased amount of cortisol. And due to decreased amount of cortisol, there is increased ACTH. So this ACTH is stimulating the adrenal gland. So what will happen to the size of adrenal gland? That is going to increase. So you are labeling this condition as congenital adrenal hyperplasia. There is increased ACTHs. The most common cause of this is 21-hydroxylase deficiency. And this is an enzymatic deficiency. And you should remember mostly the enzymatic deficiencies are autosomal recessive. I am not saying always. I am saying is mostly. So this is autosomal recessive. So our first 2 points are ruled out. In this 21-hydroxylase deficiency, remember there is mineralocorticoid deficiency. There is glucocorticoid deficiency. So both are deficient, mineralocorticoid and glucocorticoids. And if they particularly both are deficient, they lead to the salt wasting crisis. So salt wasting crisis does not mean hypertension, it means hypotension. There will be hyperkalemia, and there is hypoglycemia. Apart from this, in this condition, there is increased androgens. Increased androgens, right? These are the features. So this C is also ruled out. And this 17 hydroxyprogesterone level, this is another one liner to be remembered. It is used as newborn screening test. This is particularly used as what? Newborn screening test. So what we say here, first they are ruled out. So the answer goes in the favor of D choice. This is the answer D here. This is the true regarding this. Moving on to the question number 5. According to the integrated management of neonatal and childhood illness, all are the features of severe dehydration in child except. So severity of dehydration is a sum question which is asked in FMGE exams very frequently. So we basically study in the nutshell. We are talking here is the severity of dehydration. Severity of dehydration. So when you classify the child into dehydration, there are 3 categories. One is the minimal or no dehydration. One is some dehydration. One is severe dehydration. So what you need to understand is, if you normally divide something into 3, you will say mild, moderate, severe. This is not like this. This is minimal or no. This is some, and this is severe dehydration. One thing you can classify is by the mental state. Mental state. Here your child is alert. In the some dehydration, the child is irritable or the child is restless. And here the child is lethargic. So alert child, irritable or restless child, and the lethargic child. If you consider thirst, here the child is normal thirst. Here the child is thirsty. And here the child is not able to drink. Not able to drink. Going on to the third point is the urine output. Urine output, here it is normal, here it is decreased, and here it is minimal. Fourth point is the skin turgor. The skin turgor means you take basically the skin, you pinch off the skin, you look how much time the skin is taking in going back, and this is always checked on the abdomen. So if you do here, this is particularly instant recoil. Instant recoil. This is what we see is the slow recoil, and that is less than 2 seconds. And here it is very slow recoil, which is more than 2 seconds. Just remember these 4 points and your each and every question of severity of dehydration is solved. Minimal, some, or the severe dehydration. In this question, if you see, what we have asked is the features of severe dehydration. Decreased level of consciousness, yes. Not able to drink, yes. Skin turgor more than 3 seconds, yes. But irritability is a sign of some dehydration. This is irritability is a sign of the some dehydration, right? So we are going to now question number 6. A 3-year-old child has history of cough and cold since 3 days. On examination, respiratory rate is 36, no chest in drawing, and accepting feels well. Child responds to verbal command. Best advices. Basically, a child has come, 3-year child. Mother is saying my child is having cough and cold, and we need to know whether this child is having no pneumonia, pneumonia, or severe pneumonia. So if you get a child, there is no finding. No finding means no fast breathing, no chest in drawing. You say this child is having no pneumonia, and you just tell the parents follow up after 5 days. Follow up after 5 days, right? If in the child there is fast breathing, in the child there is fast breathing and or chest in drawing. There is fast breathing and or chest in drawing. We are not saying that both are there. Maybe fast breathing, maybe chest in drawing, maybe both present. You label it as pneumonia. And if you label it as pneumonia, what you give is you give oral amoxicillin for 5 days. Oral amoxicillin for 5 days, and there is follow up after 2 days. After 2 days. This is important. In no pneumonia, it is follow-up after 5 days. Here, this is follow-up after 2 days, which is important, right? And what is the criteria for the fast breathing? If a child is 2 to 12 months, you consider more than 50 per minute. And if the child is 12 to 59 months, you consider more than 40 per minute. And the third category, if there is danger signs present, right, or there is presence of stridor, danger signs present or there is presence of stridor in calm child, presence of stridor in calm child, you label it as severe pneumonia. So what you do is you give injection ampicillin plus gentamicin, and that is followed by referral, or you can give injection third generation cephalosporin. So this is in the nutshell regarding the pneumonia. So if you see here, respiratory rate is 36, that is well within the normal range. No chest in drawing, accepting feed wells, that means no pneumonia. So in the no pneumonia, what you tell to the parents, no antibiotics are needed and you need to do the follow-up after 5 days. That is the right advice to be given to this child. Moving on to the next question. Preterm child suffered from hypoxic ischemic encephalopathy causing periventricular leukomalacia. This causes spastic diplegic type of cerebral palsy. In a preterm child, due to HIE, that is hypoxic ischemic encephalopathy, there is the word which you should remember, periventricular leukomalacia. And this periventricular leukomalacia, this selectively affects the fibers which are supplying the lower limbs. So what happens is there is increased tone in the lower limbs. This selectively affects the fibers supplying the lower limbs. So there is increase in the tone in lower limbs, which results in the spastic diplegic type of cerebral palsy. And always in the cerebral palsy, you should remember it is non-progressive. This is non-progressive. Muscular dystrophies are progressive, but cerebral palsies are non-progressive. Right? So you have to just choose one. They are asking about cerebral palsy. It is not progressive. It is pure motor disorder. There is no genetic predisposition. It is painless condition. And in spastic diplegic type of cerebral palsy, there is increased adductor tone in both lower limbs. So what happens is reduction in both, it becomes like this. So for this we are using the word is the seizuring of legs. Right? So simple question, we are just asking the point, is cerebral palsy progressive or non-progressive? We just need to remember cerebral palsy is non-progressive. Moving on to the next one. 4 days old child is noticed to have yellowing of skin and eyes. On lab investigation, there is increase in the unconjugated bilirubin. All of the following can be the cause except. First is physiological, very well, because in physiological there is increase in unconjugated bilirubin and this never presents on day 1. This can present on day 2, day 3, and the physiological can persist. It can persist up to day 14 in a term child and day 21 in preterm child. It can persist up to day 14 in term child and day 21 in the preterm child, right? So that does not mean. Breast non-feeding jaundice very well presents in the first week. Mother is not giving optimal feeds or the child is getting suboptimal feeds. So as the child is getting suboptimal feeds, there is particularly, I am talking of C choice here, there is increased enterohepatic circulation. Which increases the unconjugated bilirubin. If there is hereditary spherocytosis, more of the RBCs will be broken. And if more RBCs are broken, there will be increase in the unconjugated bilirubin. Right? So this is there, this is there, this is there. But in the torch infections, always remember there is increase in conjugated bilirubin. Conjugated bilirubin. Right? Torch infection and metabolic disorder, maybe galactosemia, tyrosinemia, always remember there is increase in the conjugated bilirubin. Right? So simple question. In rest all of them there is increase in the unconjugated bilirubin. Moving on to the next one. Pansystolic murmur is heard in all of the following congenital heart disease except. Now first is simple, VSD. If you just see pansystolic murmur is present in VSD, mitral regurgitation and tricuspid regurgitation. So of course this will be heard in VSD. Now the confusion part is in tetralogy of Fallot, there is one VSD and there is one pulmonic stenosis. But VSD, there is no murmur. There is no murmur of VSD. Remember this in TOF. Why there is no murmur? Because in TOF, the pressure in right ventricle, left ventricle, pressure in right ventricle, left ventricle and aorta all is equal. And if the pressure is equal, there is no murmur of VSD. There is no murmur of VSD. Only murmur is of pulmonic stenosis, that is the pulmonic ejection systolic murmur. Pulmonic ejection systolic murmur. Right? In the abstinence anomaly, which is an anomaly of particularly the tricuspid valve, there is tricuspid regurgitation. And if it is a tricuspid regurgitation, there has to be a murmur of what? There has to be a murmur of particularly the pansystolic murmur. And tricuspid atresia, there is presence of VSD which produces a murmur. There is presence of VSD which produces a murmur. So you can remember this question in two ways, which are the three congenital heart diseases where you get a pansystolic murmur. It is VSD, abstinence anomaly, tricuspid atresia. And the another thing, in TOF, which murmur is not seen, murmur of VSD is not seen, there is only a murmur of pulmonic stenosis, that is pulmonic ejection systolic murmur. Pulmonic ejection systolic murmur. Going on to the next question. 2-year-old child having T lymphocyte defect is having fever, seizure, neck rigidity and altered sensorium. A presumptive diagnosis of meningitis is made. Most likely causative organism is. So they're just asking about the causative organism here. So there are certain things which you should remember. Staph aureus is the causative agent of meningitis if there is meningomyelocele. Meningomyelocele. Staph epidermidis, which you also call as cons. Coagulase negative staphylococci. This is the causative organism if there is ventriculoperitoneal shunt. Ventriculoperitoneal shunt, because what you study, this is the causative organism in prosthetic material. And this ventriculoperitoneal shunt is a prosthetic material. So in this case, you will get this causative organism. Listeria monocytogenes is the cause in T cell deficiency. T cell deficiency. This Streptococcus pneumoniae, this particularly is the cause if the child has got asplenia, child has particularly hyposplenia, right? Or there is fracture skull. In all of this condition, the cause of meningitis particularly is, most common cause is the Streptococcus pneumoniae. Because in asplenia or hyposplenia, what you study is increased incidence of encapsulated organism, which can be Streptococcus pneumoniae, Meningococcus, H. influenzae. All three can cause meningitis, but out of the three, most common is Streptococcus pneumoniae. So therefore we have chosen the answer here, Streptococcus pneumoniae. So we are just asking here T lymphocyte defect, and the answer goes in particularly favor of what? That is the Listeria monocytogenes. Listeria monocytogenes. Going on to the next question. 9-month-old child has come for measles vaccination. All of the following developmental milestone can be seen in this child except waves bye-bye, that comes at 9 months. Always remember, when the child comes for the measles vaccination for the first time, he waves bye-bye for the first time. So this is okay. Object permanence. This comes at 9 months. There is an object. You cover it with a cloth and you are saying to the child, magic lost. Child uncovers the cloth and shows you the object. He says, no magic, no lost. He understands particularly that objects are permanent. Stand without support is at 12 months. Stand with support is at 9 months. And clapping again is at the age of 9 months. 9 months something is which is a very, very important milestone criteria. Waving bye-bye, object permanence, standing without support 12 months, which a 9-month child cannot do. So therefore the answer here is stand without support. And if they ask you stand with support, the stand with support, the age is particularly 9 months. 9 months. 3-year-old girl. Now it's a 3-year-old girl come with the history of fever, vomiting, increased frequency of micturition. There is generalized tenderness present over the abdomen. To diagnose UTI, best way to collect urine sample is. Right. Now suprapubic aspirate you usually do in the child where particularly the micturition control has not come. But a 3-year-old child, definitely you will like to go for the midstream clean catch urine. Right. That is non-invasive. So you will go for the midstream clean catch urine. That is the best in a 3-year-old girl. Right. Suprapubic aspirate you can do in an infant. And in the midstream clean catch urine, what is the significant bacteriuria? Midstream clean catch urine, what is particularly we say is the significant bacteriuria, right? So if it is particularly boys, in the boys we say more than 10 raised to power 4, and in the girls we say more than 10 raised to power 5. But in a suprapubic aspirate, even a single bacteria is significant because this is done under total sterile conditions. So single bacteria in a suprapubic aspirate, that is important. But in a 3-year-old child, you will go for the midstream clean catch urine, which will tell you about the significant bacteriuria. 5-year-old boy has history of diarrhea associated with passage of blood since 3 days. Child has not passed urine for 12 hours and is appearing pale. Hemoglobin is low, that is 9.5. Platelet count is low and WBC is 12,000. Next line of management is. So if you particularly look at the picture, child has not passed the urine, that is one thing. There is thrombocytopenia, that is another thing, right? And the RBC is particularly, there is pallor which is there. All this puts in the picture of hemolytic uremic syndrome. Hemolytic uremic syndrome. And this HUS is following diarrhea. So if this is following diarrhea, either the cause can be E. coli O157H7 or it can be Shigella dysentery. It can be Shigella dysentery. So out of the two, there is one cause. Either it is E. coli O157H7 or this is Shigella dysentery. Both are gram negative and gram negative produces endotoxin. Endotoxin, right? So you will not give antibiotics here because if you will give antibiotics, bacteria will come, toxin will come out, the problem will increase. So this is particularly not given. Even if there is thrombocytopenia and if you give platelet here, there is increased risk of thrombosis. There is increased risk of thrombosis because what exactly is happening here? This endotoxin damages the blood vessel. This damages the blood vessel. So if the damage to blood vessel is there, there is formation of thrombus. There is formation of thrombus. This thrombus consumes the platelet, causing thrombocytopenia. This is a thrombus in a small vessel. So when the RBC will pass through the small vessel, RBC will be hemolyzed. So the name comes hemolytic. And the thrombus is in small vessel, that is glomerulus. Glomerulus is a tuft of capillaries. So in the glomerulus there is thrombus formation. So blood will not be filtered to form the urine. So therefore there will be uremia. There will be uremia. Right? That is the thing. So you don't give antibiotics here. You don't give platelet transfusion. And 9.5 gram is not an indication for particularly the RBC transfusion. So out of the 4 best appropriate answer here given is that is hemodialysis. Hemodialysis is the right answer for the hemolytic uremic syndrome. Next question. 2-year-old child is on chemotherapy for ALL. Neutrophil counts are low and child has developed fever. Next line of management is right. In the acute lymphoblastic leukemias, ALL we are talking acute lymphoblastic leukemias, there is anemia which can be seen. There is thrombocytopenia which can be seen, and there is granulocytopenia. Right? So even if you are giving the chemotherapy, this might take some time. So if it will take the time, so till that time anemia, thrombocytopenia and granulocytopenia is there. So if an ALL child develops fever, you should always think of infection. So what should be your first step? You should take a sample of blood culture and you should start IV antibiotics. Before starting intravenous antibiotics, you should always take a blood culture. Now, why not oral antibiotics? Your child is already on chemotherapy. That means the child immunity is depressed, immunodeficient. So immunity is already low. So why to take risk with oral antibiotics? And you want to start IV antibiotics. And once you start IV antibiotics, then you take a culture, the report can change. So you should always take a blood culture and you should start the IV antibiotics. Moving on to the last question here. A 3-month-old child has come with history of difficulty in breathing and wheezing since 3 days. The age is 3 months. There is history of low-grade fever for 3 days. On examination, bilateral rhonchi, fine crabs, chest X-ray, hyperinflation. Right. Now, if you see here, all these findings are suggestive of bronchiolitis. Bronchiolitis. Remember, the age group in the bronchiolitis is 1 to 6 months of age. And here your child age is how much? 3 months. Child age is how much? 3 months is there. It is the most common cause of wheezing in infant. It is the most common cause of wheezing in infant. There is bilateral rhonchi and fine crabs. There is bilateral rhonchi and the fine crabs, right? So if you see here, there is bilateral rhonchi and the fine crabs which are present here. On the chest X-ray, there is hyperinflation. On the chest X-ray, there is hyperinflation. Right? Each and every finding is towards the bronchiolitis, and in the bronchiolitis, always remember the things: no antibiotics, no steroids. Remember this: no antibiotics, no steroids. The only presumptive treatment is particularly humidified oxygen. So you should give here humidified oxygen. That is the right answer here: humidified oxygen. Right? So this is regarding the bronchiolitis question, right? I hope you must have liked the question. Just revise your topics and all the best for your exam. Thanks.